Okay, hello and welcome back. Today we'll discuss Guillain-Barré syndrome, and I would like to give you a heads up what this topic is, how relevant it is in our day-to-day practice. Here you can see I've symbolically presented a peripheral nervous system. Anything that is coming out from the spinal cord here are the peripheral nerves. In Guillain-Barré syndrome, there is this peripheral nerve damage. Also, cranial nerves are also a part of peripheral nerves that can get involved. But how these peripheral nerves are getting damaged in Guillain-Barré syndrome? So we can see here in our right lower corner, autoimmune disorder. GBS is an immune-mediated inflammatory disease involving our peripheral nerves, particularly the myelin sheath, and also in some other variants, the axons can get involved. Other thing you can see here is absence of reflexes. Absent deep tendon reflexes is a characteristic of GBS. Also, sometimes there will be a mention of rubbery legs. Therefore, bilateral symmetrical limb weakness also is a characteristic of GBS. And also here, if you can see, this is an ICU bed wherein roughly 30% of the patients of GBS might require a ventilatory support. Therefore, discussing this topic is very important and we must understand how it develops and how it is treated. Defining GBS is very simple. It is an immune mediated demyelinating condition involving polyradiculoneuropathy. The roots as well as the nerves are getting involved. The most common variant of GBS is AIDP. AIDP stands for acute inflammatory immune mediated demyelinating polyradiculoneuropathy. Nothing new to learn here as we have already summarized in the definition part. Pathogenesis. So there is some antecedent event. Say for example, there is a trigger, and most commonly in approximately 70% of the cases of GBS, there is a trigger with this, either there is a respiratory infection or a GIT infection, and most common organism responsible for this is Campylobacter jejuni. On successful infecting the patient, there is this exposure of its antigen, the body does not recognize it, and there is a misdirected response to the antigen, and there is this term molecular mimicry. Antibodies are misdirected to the self antigen and they ultimately affect our peripheral nerves. How? With the help of autoreactive T cells against peripheral myelin proteins and complement mediated demyelination. Therefore, in GBS, both the cellular and humoral immunity plays a role, ultimately leading to GBS. What are all the organisms responsible for generating or developing GBS? The most common is Campylobacter jejuni. Other than that, there are human herpes virus, HIV, cytomegalovirus, Epstein-Barr virus, hepatitis E virus, and SARS-CoV-2, which was responsible for COVID-19, is also playing a role in development of GBS. Otherwise, immunization has also showed linkage to the development of GBS, especially swine flu vaccine. Then influenza vaccine, older rabies vaccine, which are not used nowadays, also that, and COVID-19 vaccines have also shown, which contain adenoviruses, showed in development of GBS. So GBS has basically four variants, out of which we know that AIDP is the most common variant. Roughly 90% of all the patients of GBS will have AIDP. AIDP stands for acute inflammatory demyelinating polyneuropathy, as we all know. It affects roughly 90% of all cases are AIDP only. It is a good, like the rapid, there is a recovery is rapid, but then anti-GM1 antibodies are seen, but they are only seen in less than 50% of the patients. Therefore, this is not specific to AIDP. What is the basic pathophysiology of AIDP? Here it is demyelinating. As the name suggests, here it is demyelinating. Demyelination is going on. So uh, the pathogenesis part has the first attack on the Schwann cell surface. As we all know, Schwann cells forms our myelin. Therefore, there is damage to the Schwann cell surfaces. There is widespread myelin damage, macrophage activation, and lymphocytic infiltration, and ultimately development of AIDP. The other variants are Aman and Amsan. Aman is acute motor axonal neuropathy. As you can see here, now the axons are getting damaged, and of that also particularly the motor nerve fibers. Here, the antibody by the name of anti-GD1A antibody is specific to Aman. So here the pathogenesis revolves around the axonal damage. First attack is at the motor nodes of Renwire. Macrophages are activated, lymphocytes get infiltrated, and ultimately our scavenger macrophage will lead to the further damage to the axons. The third variant is UMSAN, wherein motor and sensory axonal neuropathy occurs. So, Aman and UMSAN, relatively, they are uncommon. The most common is AIDP only, and here also the basic pathology is axonal damage, same as like that of Aman. And the fourth variant is Miller-Fisher syndrome. Miller-Fisher syndrome has a triad, that is ophthalmoplegia, ataxia, and areflexia. Here, the specific antibody, that is anti-GQ1B antibody, is present in more than 90% of the patients with Miller-Fisher syndrome. But keep in mind that there will be areflexia, but there will not be any limb weaknesses. So there will be ophthalmoplegia, ataxia, and areflexia without any limb weakness, plus this characteristic antibody. Pathology can revolve between axonal or demyelinating condition. Okay, so GM1 and GD1A ganglioside antibodies. So first of all, we'll understand this in the immunopathogenesis part, that this anti-GD1A, what are these? So basically, these are gangliosides. GD1A and GM1 are gangliosides which are present on the nodes of the red wire, against which the antibodies are developed, which results in axonal damage. Therefore, the IgG autoantibodies against this GM1 and GD1A in Aman and AMSA. Lastly, anti-GQ1B is present in more than 90% of the patients of Miller-Fisher syndrome. So here we'll understand the mechanism, the immunopathogenesis behind AIDP first. So this A, we are going to understand about AIDP. Here, our myelin sheath, which are Schwann cells, has unidentified antigens against which our antibodies, due to molecular mimicry, our antibodies are going to attack to this unidentified antigen. There will be antibody binding, there will be activation of the complement, and there will be formation of membrane attack complex. The membrane attack complex will eventually damage our myelin sheath. Then our scavengers such as macrophage will come. It will take away all the debris and therefore lead to demyelinating injury. So as you can see here, axon is here, and on the periphery these are the myelin sheaths, and on that macrophage is sitting. So this is the pathogenesis of AIDP. Now for Aman and Amsan, as we knew that it is an axonal neuropathy wherein the axons are going to get damaged. How? That these nodes of Ranvier, there are gangliosides by the name GM1 and GD1A. These are gangliosides onto which our antibodies, due to molecular mimicry, are going to attach, and they are going to inflict a response. So basically, as we are amplifying this image, here you can see this is a node of Ranvier, then just adjacent to it is paranode, and then juxtaparanode. There are these attaching cells to it, such as Casper protein or potassium voltage gated potassium channels. But most important is our voltage gated sodium channels, which are present just at the nodal place. Now, as soon as these antibodies are getting attached and they inflict a response, there is detachment of the paranodal to myelin sheath attachments. Therefore, there will be a periaxonal space generation, and ultimately the axon, underlying axon, will get damaged, and therefore there will be and then again the complement will be activated, the membrane attack complex will get activated, and macrophages will come, and then axonal damage will occur. Clinical features. Clinical features with respect to GBS, we must understand. So see here, there will be a rapidly progressive proximal plus distal ascending areflexic limb weakness. So, whenever there will be an antecedent event, say for example, the patient had Campylobacter jejuni infection, following to it 1 to 3 weeks later, the patient might complain that he is unable to wear his chappals. Also, he might also complain that he is unable to get up from the chair. That signifies that proximal plus distal limb weakness, which is progressively occurring in an ascending fashion. Then, on subsequent days, the patient might complain that now he is also unable to raise his arms above the shoulders. Therefore, there will be a rapidly progressive ascending areflexic limb weakness. The reflexes such as knee reflex or ankle reflex will be absent. Then it will be symmetrical, bilaterally symmetrical. Both the limbs will be affected equally. There will be also sensory involvement in GBS. The patient might complain of mild distal paresthesias, tingling sensation or numbness, etc. Also, as I said, cranial nerves are our peripheral nerves. Therefore, the patient might have facial diplegia. That is, bilateral facial nerve can get involved and lead to its weakness. There can also be lower cranial nerve involvement leading to bulbar weakness, bulbar involvement. Also, autonomic dysfunction can occur. As we all know, autonomic nerves are also a part of peripheral nerve. They can also get damaged, either demyelinating or axonal neuropathy. that can lead to labile BP, that is wide BP fluctuations, arrhythmia, and orthostatic hypotension. Okay, and lastly, respiratory involvement can also occur, and that may be fatal for the patient and eventually might require a mechanical ventilatory support. All of this, plus the patient should not have any constitutional symptoms such as fever, nausea, vomiting, etc. If there are constitutional symptoms, you must uh, consider it as a red flag and must look out for other diagnosis. Okay, so these were the clinical features. Phases of progression, this is very important to understand. So here in this image I have tried to show that there is an antecedent event occurring, okay, following which, like say 1 to 3 weeks, the first symptom starts, then then the symptoms get gradually it worsens, and at one point of time it becomes plateau. So for say example, at this point, let's say after 1 to 3 weeks, the patient started developing rapidly progressive ascending areflexic lower limb weakness. Then on subsequent day, he had weakness which was symmetrically and now involving both his upper arms. Then on subsequent days, cranial nerves are getting involved. So basically, this is a progressive phase. This progressive phase will occur till first 4 weeks. After 4 weeks, the now the symptoms will not worsen anymore. In fact, these symptoms will have a plateau phase. Now there will be no reduction in symptoms, nor there will be any worsening of symptoms. There will be a plateau phase, and this plateau phase lasts for 4 weeks further. So after 8 weeks, now there will be a recovery phase. Now the symptoms will get resolving and then subsequently recovery. So this is how the phases of progression on GBS occurs. This is a phase of progression in case of CIDP, which is chronic inflammatory demyelinating, which is also a differential diagnosis for GBS. But here, as you can see, after 4 weeks, there is still ongoing worsening of symptoms. Okay, so that you must keep in mind. Now, what are the red flags? So, red flags are basically when you have to look for other diagnosis than GBS, such as when a patient has severe respiratory dysfunction with limited limb weakness at onset, then you should think other than GBS. Slow progression over 4 weeks without cranial autonomic or respiratory involvement. There is still progression going on after 4 weeks. Severe sensory signs with limited weakness at onset. So basically, at onset, there has to be some motor weakness present. Then subsequently, minor sensory symptoms will also occur. But if sensory symptoms are at onset only, then you must consider other diagnosis. Bladder or bowel dysfunction at onset. Again, bladder and bowel dysfunction in GBS occurs in later part of the time, not at the onset. Also, if there is a sharp sensory level in the torso, a sensory level present must tell you that there can be a spinal cord pathology, not GBS. Then marked persistent asymmetric weakness. As I said, GBS is a symmetric flaccid ascending weakness. So if there is asymmetry, consider the diagnosis. Fever at onset. Again, if there is CSF pleocytosis, we will discuss this in a diagnosis part, that there is albuminocytological dissociation, wherein the protein part will be much higher and cells will be much less. If you have cells more in CSF examination, then please consider other diagnosis. Okay, so these were all the red flags. Discussing Miller-Fisher syndrome, as I said, it is a triad: ophthalmoplegia, areflexia, and ataxia, plus absence of limb weakness. That is Miller-Fisher. Again, you can say that why there is ophthalmoplegia and Miller-Fisher. There is GQ1B gangliocytes, which are more prominently present in the extraocular muscle nerves, therefore, which has tendency to develop ophthalmoplegia. Okay, so this is a triad of Miller-Fisher syndrome. What are all the investigations that we will do? First of all, clinically, we must at least suspect that this patient is having GBS on the basis of all the features that we have discussed. Now, we'll have to perform a CSF examination. But keep that in mind, in order to diagnose a patient with GBS, this CSF examination must be done at or after first week. In that, we'll see albuminocytological dissociation. This albuminocytological dissociation simply means that there will be increased protein in the CSF fluid. The cells will be much less in number. This is because there is increased blood nerve barrier permeability, which tends to leak proteins in the CSF. Then again, there will be mild pleocyte, mild number of cells, roughly 10 to 20, not more than 50. It will never go above 50. If the cells are going above 50 in number, consider other causes, other diagnosis other than GBS. And second thing which we will do is nerve conduction studies or electrodiagnostic studies, in which, as per the variants, say AIDP was a demyelinating condition. So demyelinating conditions has reduction in conduction velocity. There will be conduction block. There will be prolonged F waves or absent F waves. Similarly, with Aman and Amsan, there will be a CMAP reduction. That is, compound muscle action potential will be reduced significantly in Aman and Amsan. So these are all the nerve conduction studies components which we must understand. Other than that, for excluding other differentials, we'll do a MRI contrast of spine, enhancement of the intrathecal spinal nerve roots and cauda equina will suggest that this is GBS, and also to exclude other differentials, we'll do MRI spine. Ultimately, after doing this diagnosis, we are going to how are we going to diagnose? So we did a lab examination of CSF in which it showed increased protein. How much it has to be? Like basically, it has to be more than 45 milligram per deciliter. But in GBS, it goes up to 100 to 1000 milligrams per deciliter. Plus, the cells should be less in number, and this CSF has to be examined at or after 1 week. Electrodiagnostic studies findings of AIDP, we'll discuss it now only in the next slide. And also we can do MRI spine just to so that we can exclude other diagnosis, and the nerve roots will show enhancement, which is suggestive of GBS. Now there is one point in Harrison which says that if you suspect GBS clinically, but you are not in a position to perform CSF either because it is too early or there is not no availability of nerve conduction studies, you should not wait. You should not wait to start the treatment. You don't wait and straight away treat the patient, because if it has shown that if you start the treatment 2 weeks after the onset of the symptoms, it basically does not yield good results. Okay, so starting the treatment as soon as possible is advisable. So here nerve conduction studies parameters I have tried to show, in which we have AIDP, which is a demyelinating condition, Aman, which is a motor axonal neuropathy, and Amsan, which is a sensory axonal, motor plus sensory axonal neuropathy. Now, primary pathology we all know. In all, so if demyelination is there, we all know that myelin sheath is important for the velocity, the conduction velocity. If myelin only is damaged, there will not be solitary conduction possible. Therefore, the conduction velocity will be reduced. Here in Aman and Amsan, there is no demyelination. Therefore, the conduction velocity will be normal. Sensory conduction in AIDP, which is the most common variant of GBS, there is a sensory involvement also. Therefore, sensory conduction will also be reduced. Then one part is distal motor latency. Again, if you can just visualize that there is a nerve, peripheral nerve, onto which the myelin is damaged. So for the current or for the action potential to reach from point A to point B, if there is damage to the myelin, the conduction will take more time to reach to point B. Therefore, there will be a distal motor latency. So the time taken will be more. Understood? But here it will be normal because the myelin is intact. Just the axon is damaged. But there are voltage gated sodium channels are still present. So the action potential will still be reaching their own time. Compound muscle action potential is particularly useful in assessing axonal neuropathies. So it is normal to mildly reduced in AIDP, but it is markedly reduced in Aman, also in AMSA, because these both are axonal neuropathies. Then this is sensory nerve action potential amplitude, sensory nerve. But then because in AIDP sensory nerves are also getting affected, it will be reduced, but it will be markedly reduced in AMSA. Okay, conduction block is a feature of AIDP. Okay, but it will be absent in Aman and AMSA. Again, F wave latency, it is prolonged in AIDP. We should understand what is conduction block and what is F wave latency. Basically, F wave is a two-way thing for a action potential to run. So if there is a motor neurons, if peripheral motor neuron is there, if we are stimulating at distal portion of peripheral this motor, now there will be a forward flow and the muscles will get activity, and there will be again a retrograde action potential flowing to the anterior horn cell. This will again come to the same point B. This whole two-way pathway is a F wave latency, which gets prolonged in AIDP. Understandable, because the myelins are damaged. Anyway, this whole pathway, this two-way running of the action potential will be damaged. Therefore, this F wave is prolonged. But that will be normal in Aman and Amsa. Okay. So then this is whole Brighton criteria for diagnosis of Guillain-Barré syndrome. You can pause the video. We have discussed already everything, all the features, just here, so you can just read it, go through it. Ultimately, treating. The specific therapy includes either IVIG or plasma exchange. Both of them are equally good. Both of them are equally efficacious. So we must use only one of them. Combining both is of no use. So IVIG, basically the dosage is zero point 0.4 gram per kg per day for 5 days. So maximum of 2 gram per kg per day, per week, per 5 days. Then the other is Plex, that is plasma exchange, 4 to 6 exchanges per week within first 2 weeks of onset. As I said, as early as possible the treatment should be initiated, because after 2 weeks much results will not be achieved. Then other supportive therapy monitoring, such as respiratory and cardiac monitoring, also DVT prophylaxis, chest physiotherapy, and prevention of pressure sores. Prognosis: roughly 85% of the patient with GBS will have full recovery by, let's say, several months to 1 year. But then 5% of the people will have mortality due to secondary pulmonary complications. Out of all the four variants, Amshan has the worst prognosis, and because even advanced age or severe attack or delay in the treatment can also lead to worse prognosis and eventually mortality. So this was all about GBS, and thank you for listening me. Thank you so much.